Dr. Sanjay SRINIVASAN. He is going to talk about a novel topical medication for pediatric uveitic macular edema.
Thank you, Dr. Ramesh. I would like to thank AIOS and APAO for giving me this opportunity. So, I'll be talking about a new novel topical medication for pediatric uveitic macular edema. So, I have no financial disclosures or no conflict of interest. Uveitic macular edema occurs in 8.3% of non-infectious uveitis. The thing is, it can occur even without any sign of concurrent inflammation, both in the anterior segment or in the vitreous or posterior segment as such. This is as a result of the breakdown of the blood retinal barrier and various inflammatory factors like VEGF, pro-inflammatory cytokines, IL-6, 8, TNF-alpha, IL-1, TGB are released, and this actually causes the uveitic macular edema. Now, what do we have for the conventional treatment? We have steroids in various forms, from topical, regional, depot, intravitreal steroids. We have the topical NSAIDs, the anti-VEGF, immunomodulatory agents, and biologics. This idea actually germinated from the study which was done on topical interferon in diabetic macular edema, where there was improvement, but the studies actually did not show any statistical significance. Now, how does the topical interferon act? So, it acts probably by restoration of IL-2 production, which helps stabilize the retinal barrier. The inflammatory cytokines like TNF-alpha and IL-6 are reduced, and inhibition of inflammasome activation. The inflammasomes are actually cytosolic proteins which are responsible for innate immunity. Now, there is also regulation of the VEGF gene expression and inhibition of basic fibroblast growth factor and IL-8. All this helps restore the blood retinal barrier, and also it prevents the NK cells, CD8 and CD3 cells from acting. Now, how do we do it? We have a commercially available interferon solution which comes as 3 million units per ml. The drug which we used was injection Intalpha. We took 2 ml of sterile water for injection to reconstitute 3 ml of interferon, which turns out to be 1 million unit per eye drop solution. The patient was handed over this drug. We actually estimated that the drug what we prepared was there for 2 weeks, and we actually provided ice pack to be given to the patient, because many of our patients travel long distances, and this was to be kept in a refrigerator door at 4 degrees centigrade to keep the optimal effect of the interferon. So this is the drug which we actually used. This was the one we had it. This study was done when I was in India. This was an ethics committee approved, and we actually did for adults patient initially, and with the success we actually obtained, then we actually started recruiting pediatric patients also, with full explanation of the drug and its effects from their guardians, and the study was done. Now, how did we go about? We initially started with using this interferon for pseudophakic CMOs. We used 4 times a day, and these pseudophakic CMOs were actually resistant to most of the drugs, the steroids or intravitreal or depot steroids or oral steroids. Whenever we actually stopped the medication, the pseudophakic CMO used to recur. So we also actually looked at the lens portion and saw whether the lens was actually responsible for this pseudophakic CMO, but fortunately for us, the lens was actually in the bag in the position. So we could not attribute this pseudophakic CMO to any cause. So this was one of this case. Our initial success was with inflammatory CMO in a patient with cat bite who had a pan-uveitis kind of picture, and this gave us impetus to actually try out on a few things. But all was not rosy, so we used the same model of 4 times a day for some of the uveitic macular edema in adults, which we define as a standard therapy. It worked in some patients, but it didn't work in everybody. So we actually went back and we thought that probably these patients may need more intensive medication. So we tried 6 times or 3 hourly medications, and surprisingly it worked. Now I'll describe the cases which we actually used this topical interferon. This is a 10-year-old Asian Indian boy with presenting visual acuity of 20/100 and 20/200. He had multiple ocular comorbidities with deep stromal corneal scar, no ghost vessels, keratoconus, early posterior subcapsular cataract, and bilateral IU. So the systemic investigations were unremarkable. We could not find any cause, so it was more likely idiopathic. So a patient was initially started on topical and systemic steroids, but patient was not responding well. So in consultation with rheumatologist, we started with methotrexate and folic acid. There was non-compliance during COVID-19 lockdown, and patient was self-medicating. In India, topical steroids are available over the counter, so anybody can buy and keep using it. So also the patient had repeated urinary tract infections with all this steroids and methotrexate. So he went to a local doctor and he put him on nitrofurantoin. So this happened on and off. And subsequently he developed intolerance to methotrexate. So in consultation with the rheumatologist, we actually got him on cyclosporine. Then we actually reduced the methotrexate dose, and cyclosporine dose was upped. We tried diflupred, which is actually more penetrable in the posterior segment, but bromfenac, all this didn't help very much. So a detailed discussion was done with the parents, saying that so we have tried both systemic and ocular medications. We offered injectables in the eye, but the parent was not very keen for any injectables. This is the OCT actually showing the cystoid macular edema at presentation to me. And so this illustration, actually this is in publication, so that's why I put ABCD. So the first one is at presentation to me. Then after I started with topical interferon, you can see the cystoid changes. This is about 2 months after initiation. So the cystoid macular edema has reduced. The patient is still on cyclosporine and methotrexate, no steroids, no NSAIDs. And then I reduced the dose. The D is at 3 times the dose, E is at 2 times, and F is at 1 time. So he has remained like this with topical interferon, and finally we were able to wean him off the topical interferon. He is just only on systemic medication. So this is the final outcome we have been able to achieve with complete resolution of cystoid macular edema. The second case is a 12-year-old Asian Indian girl with bilateral panuveitis diagnosed in 2017. She was treated elsewhere. Surprisingly, only her right eye used to get cystoid macular edema. Again, the systemic workup was negative. She had also posterior subcapsular cataract only in the right eye. She also had a few episodes of vitreous hemorrhage which resolved on its own. Initially started on 7.5 milligrams of methotrexate up to 20 milligrams. Funnily enough, this patient used to have recurrent herpes simplex infection of her lips. So this made the clever father to actually stop the methotrexate and start the acyclovir again off the counter, because once I had started, then he used to do it on his own. And when the cystoid macular edema recurred, he used to turn up and see me. So this patient also I started on, this one was quite thick actually, the cystoid macular edema. Again, with the initiation of topical interferon, it gradually reduced, and it's quite resolved after about 5 months. The third case was a more challenging case of a bilateral panuveitis with secondary glaucoma and cataract. At her presentation elsewhere, she had a vision of counting fingers and 1 meter. Intraocular pressures were also very high. So these were the procedures done. So she came to us when she had been on oral steroids, topical steroids, and persistent systemic cystoid macular edema. So after initiation of topical interferon 1 month later, there was some reduction. But unfortunately, 2 months later, this again recurred despite using the topical interferon. So in summary, I have these 3 cases, which 2 cases had very good improvement, and there was no recurrence after initiation of topical interferon. All these patients were still on the systemic immunosuppressants in the same dose, and there was no additional medication which was given. Just to give a brief on interferon, it's a large molecular weight substance which actually, when you put it in the eye, because of poor conjunctival and corneal penetration, we are not still sure how it's actually acting. But probably there is a mechanism of sclera which is allowing it to actually enter into the posterior segment. Also, this was explored by my colleague who tried posterior subtenons for one of the cases which was published earlier this year. There have been newer agents for uveitic macular edema, including faricimab. So this actually helped in resolution. So probably in our cases, none of the guardians were actually in favor of getting any injections. So that is why we did not proceed with injections for them. So the limitations of this is it's a short case series. It worked in 2 patients with pediatric uveitis. It's an off-label drug. We didn't have any complications. The complications in some of our elderly patients were like conjunctival congestion, punctate epithelial erosions, photophobia, some lid swelling, but in our both pediatric or all the 3 pediatric patients, we didn't have any of those complications. So probably we can explore this as an effective alternative for treating persistent CMO in pediatric patients, and it is also helps to reduce the dosage of topical steroids. So I'd like to invite you to the 35th anniversary meeting in Singapore next year. Thank you.
Thank you. Well, I know some of you have to leave for the next session, and we have to empty this room in 5. There's a next session that's going to start in 5 minutes. So we'll be outside. If any one of you have any questions, please come to any one of the speakers for any additional questions. Thank you very much for attending the best symposium at the APAO.